Okay, welcome everybody. So good to have you again for another session of our nephrology fellow rounds. So today, certainly a bit of a shift, even though there have been not necessarily a theme or a path that we've been going with these rounds. We have been jumping around a bit, but wanted to cover this article mostly just because I had come across it fairly recently and was pretty excited about the article and thought it was just an interesting thing to use as maybe some framework on how we look at GN in our patients. And so this review article, obviously it was big, it was 19 pages, but there were lots of figures and some of these figures took up whole pages. So it wasn't as brutal as what it certainly seems to be. But I thought the paper was interesting because it gave both very basic information and then very detailed information at the same time. I mean, the fact that there is number one, just a anatomy of a glomerulus, how that needed to be essentially an entire page, means that they're presuming people don't know what a glomerulus is when they're reading this article, which is great. The fact that they have a glossary, right, of all the different terms that are used throughout the manuscript is interesting, helpful, I guess. Yeah, they have a glossary which includes nephron and glomerulus, but then like APOL1 and other things as well too. So it was an interesting article because I think it presumed that you didn't know anything about GN, which is great, and then dives pretty deep into kind of a categorization of the various pathologies and thinking about it more in terms of an etiologic framework. So I thought that would be an interesting way to just think more about our patients who have immune complex glomerulonephritis, because we really just kind of limit our diagnosis to immune complex GN. And in my experience, I rarely find a trigger for it. Even with infectious disease testing, it often comes up negative, or they've had antibodies to Borrelia for years and years and years, and we still can't even definitively prove it. So I thought that this was just an interesting way to maybe think about the etiology from the immune system pathway differently, because I think I'm always thinking about it on the back end, like the complexes that are there, still working on trying to understand and wrap my brain around complement and how that could be activated compared to B cells and T cells. And I think this paper did a decent job of starting to tease out some of that information, at least for me overall. So let's get into it. The first thing, I can't say I was really that familiar with any of these authors. I don't know, Rachel, Mary, Jess, if you guys have heard and familiar with these folks.
Nope, I just was going to say I don't know who any of them are. Does it have their location? Like their
Yeah,
affiliation?
I think they're all, a lot of them are European. So let's
Yeah, it looks
see.
like Munich, Australia,
The
Italy.
From the
Romagnani,
Mayo.
yeah, the Romagnani author sounds familiar, like on a lot of papers, but we don't know any personally.
Yeah.
Yeah, it's just interesting. Yeah, I would have imagined, I could have thought of a bunch of other names for this, not to at all say that these people aren't trustworthy, but they weren't names that jumped to the forefront of my mind in terms of thinking of glomerular pathology in people. But yeah, let's go ahead and let's kind of dive into it. So they obviously go through the overview of the glomerulus and what it does and what the pathologies might be. And they kind of introduce how you can have stimulation of the immune system from a lot of different pathways and how that can result in an aberrant response that the kidney is then implicated in damage, whether that's because the immune system's attacking things in situ or there are circulating immune factors that are leading to the kidneys becoming involved and affected one way or the other. So they, let's see, where do I want to start with? So I think one thing that is important that they didn't necessarily, I think they said it, but it wasn't maybe as explicitly stated as I thought it could be, or at least what I didn't get from it, is when we see our lesions, when we see the pattern and we get our diagnosis that on our kidney biopsies, what we're seeing is not the disease. And I think this is something that took me a long time to really understand, that when we see membranoproliferative glomerulonephritis, that is not a disease. When we see membranous nephropathy, that is not a disease. You are looking at the reaction pattern. You are looking at the response of the kidney. And there are many different things that can cause an MPGN. There are many different things that can cause membranous, mesangial-proliferative, minimal change disease, glomerulosclerosis, that we're talking about the pathology, not a disease. But I think we look at that in much different terms, and maybe that's partly because we don't have a lot of the sophisticated ways to identify what the triggers might be, number one. Number two, we lack more refined treatment for many types of immune complex GN. Whether it's a membranous or a membranoproliferative pattern, many times we're probably going to turn to steroids and mycophenolate, maybe cyclophosphamide. Maybe we think about cyclosporin, even though Shelley Vaden's paper suggested it wasn't helpful. But that was from 1995, when we didn't even have proper biopsy evaluation of patients, number one. And number two, it was using Sandomune. It was using unmodified cyclosporin, which has totally different pharmacokinetics and bioavailability than cyclosporin modified. So that study is unfortunately just dated, that we really can't apply its results to current cyclosporin plan if we were to use it. So I think as it starts to introduce some of these patterns that are here, that is something I think that for me, and I don't have to certainly explain this to Mary and Rachel and Jess, but for clinicians, that when we get back these reports, that is not a diagnosis. That is not it is a diagnosis, it's not a disease. MPGN is not a disease. Now, do I list that as the patient's problem in their medical record? Yes, I do, because I don't know what their disease is. I know they have immune complex glomerulonephritis that results in a membranoproliferative pattern, but I don't know what that cause is in nearly every single case of immune complex GN. And I think if we stop with, I have a diagnosis, it's a membranous glomerulonephropathy, that is not the complete picture. That is identifying that there's immune activation and likely identifying a need for immunosuppression, but it's not identifying what the disease is. And if we always are saying, well, that's our diagnosis, we're done, then we're never going to advance this further. So everything we're talking about is reaction patterns, and it's not the disease. And that is a huge point that I think clinically we need to understand as we move forward, to try to help us understand that we need to be looking for these triggers. We need to be finding the agent that has triggered that membranoproliferative response within the glomerulus, not that that is the underlying disease. I don't know if anybody else had any comments or thoughts just on that kind of general concept.
So this is Rachel. I raised my hand. I'm going to now lower my hand, but I think everything you said is spot on, and I think that the reason it has evolved this way is that we are 30 years behind, obviously, human medicine, and we are using almost historical classification, or we were using almost historical classification systems that were published in old versions of their textbooks So before the WSAVA project got initiated, we were still calling things type 3 MPGN and thinking that that was a disease. And we were publishing papers with a case report of a type 3 MPGN. And so when I was doing my fellowship at the med school, that was kind of as C3GN was starting to be recognized. And then, over the course of that time, we realized C3GN actually has its own subcategories as well. And so those things are all, 10 years old in human medicine, and we are still kind of figuring out, do they actually exist in veterinary medicine as well? So there are certain diseases that are quite classic in humans that cause glomerulonephritis pattern, and we just don't see in veterinary medicine. And I'm assuming we will eventually be able to say there are certain diseases that happen in dogs and cats that just never happen in humans. What we need are better serologic biomarkers for some of these diseases to see if they are comparable. For example, C3 glomerulonephritis, you have a very specific complement serology, and we don't even have a way to measure complement levels in dogs and cats. I can't find it anywhere. And so there are certain times where it's just because we don't have the exact same overall assays, it will be very hard for us to say whether lupus happens in dogs and cats, lupus nephritis, happens in dogs and cats until we get those biomarkers. And once we do have those biomarkers, then I think we will say, okay, this is the canine version of lupus nephritis. They don't have the ANA that we think about in humans, but they have all these other autoantibodies. And so we think that this is a model of lupus. But I think it's just because nobody's writing the papers. And I think with your comment about Shelley's cyclosporin paper, because it exists, people think it's already been tried. So nobody repeats the study with modern formulations of the drugs and with a better characterized cohort of patients. So you need to write those papers, JD.
I'm on it. I love it. Yeah, I think it's interesting, and because we're using terminology that is still outdated, it makes it more challenging when you are trying to really dive into what is known in people and try to apply it to your patients. And I think the classic scenario, which is not in this paper because this is talking about really immune-mediated GN, but the classic example would be focal segmental glomerulosclerosis. When we see FSGS in our patients, it is not the typical disease that is there in people. So in people, they absolutely can get the reactive pattern of FSGS, and in some of those patients, what is driving it is this soluble permeability factor, which is not even completely well characterized, which is cool just because it's going to be characterized. So it's reading back through a lot of these papers that we've gone through, we've talked about, well, they didn't know that this was Tams horsefall mucoprotein, or they didn't know it was this, and now we understand. Like, we're living in a time where we don't know what the causative agent of FSGS is, but we will. But as far as we know, we haven't really seen dogs have that same type of phenotype where dogs with FSGS have this circulating permeability factor that tends to be very, very responsive to steroid therapy in people. So when you look at FSGS papers in humans, you're going to see a lot of steroid trials and whatnot, which have not anecdotally been effective in our patients because they probably are having a completely different disease, even though the patterns look the same. And it makes it challenging to then apply translationally what's seen in humans to our patients when the patterns are not the disease, patterns are not the pathogenesis, patterns are not the etiology. And I think this paper did a good idea of introducing that, but I really want to hit home on that being probably the most important take-home thing, period, that I took from this paper. And I think to Rachel's point, not having the ability to measure complement has allowed me to ignore most of what I learned in vet school about complement. You know, I learned something, remembered just barely enough to pass an exam, and then never really applied it clinically. You know, maybe talk about a little bit for intravascular IMHAs, talk about a whole lot more with glomerular disease because we can stain for complement, but if I then take it further and say, okay, well, can I draw up on this whiteboard how a stimulus can lead to complement deposition within the glomerulus? I can't. I can't do it off the top of my head, and I can't do it to a sufficient level. So not having that be something that we measure with diseases that makes me interpret it, remember it, and have it be part of the pathophysiology means that it's just not something that is going to be well understood in my brain. You know, I don't hold on to things well unless I'm constantly seeing it and reviewing it. So the lack of these assays not only prevent us from characterizing things, but also just allows us to skip the whole middle section, that we get to the end, that we have something that led to the immune system causing antigen antibody complexes being deposited in the kidney. The mechanism of that, not so sure of it. The trigger of it, not sure what it is. There had to be some trigger. So we're presuming a trigger was there. We have no idea what it is. Something happens, and then we're left at the end. And we're probably missing a lot of opportunities to manage these patients differently, or to find a trigger that might still be existent that maybe we can still minimize to help change the course of the disease. Or maybe not, but at this point we certainly don't even know one way or the other. So,
And I think from a pathology standpoint, when I've lectured this to people who are trained pathologists and board certified, and I have clarified that there are different pathogeneses to get to, let's say, a membranoproliferative pattern. So both complement-mediated glomerulonephritis, which is a problem with the complement system, and you cannot remove regular deposits that would normally filter through a glomerulus. You start to actually make deposits of complement itself, and it has very, very few immunoglobulins in it. So it's a complement-mediated electron-dense deposit. We can see that on immunofluorescence, and we can also measure complement levels in the blood. You would treat that completely differently in a human, because in a human, you need to then interrupt the complement system. You need to interrupt the overactivation of the complement system. So it is very important for you to get the diagnosis correct in humans. We don't have complement system blockers in veterinary medicine yet. But that's why there's plenty of times where pathologists say, well, why would you care? It all looks the same on histology. Why do you care which one was making the deposit? And if we ever got to the point where we had personalized medicine and veterinary medicine, you would actually need to know, are these electron dense deposits made of immunoglobulins, and the immunoglobulins are stimulating complement, or are these immune deposits completely made of complement? So knocking down antibodies are really not going to do anything. So it is important. It's just something where we don't have the methods yet.
Right. And that mindset is completely unhelpful. To say like, well, you know, what does it matter because we don't have those abilities to manage the patients differently is true today. But the goal is we want to refine these diseases. We want to refine our therapy so that that can be something that can happen. And yes, we don't have, you know, rituximab doesn't work in our patients, but they're working on a veterinary anti-CD20. So like that therapy is in the works, and there are papers that have looked at it for cancer. So just to say that, well, those therapies don't exist is basically stopping any momentum that we can try to develop. Because when I read this paper, I am pumped. I am psyched. I want to measure curl and NEF1 and APO1 and all these antibodies that we can possibly can to try to just see what shakes out and what might be some of the triggers for these patients. And I mean, it's wide open for us. We just need money and time and the ability to start looking at this, but it's an untapped area that could absolutely develop into very directed therapies. And presuming that there isn't going to be, it just means that we're never going to get it. We're never going to understand, we're never going to advance medicine if we just are stuck saying, well, we don't have that option now, so why do anything? Well, because let's do it tomorrow. Let's do it the day after that. Let's make it happen. That's soapboxing for me. I wish I would say that that's the last soapbox, but you'll probably hear me yelling from the soapbox continually throughout today. Okay, let me see what I had in terms of just notes that I wrote. Pattern doesn't equal pathology. Just to remind myself of what we see with posse immune, since we don't see it too often. And so I did like this quote here, that pathology lesion-based GN categories, which is really how we look at things, membranoproliferative, membranous, angioproliferative, often do not dissect the diversity of the underlying immunologic disorders, which require different treatments. And hence, treatments based upon those categories may result in many non-responders. And this is so classic. How many GN patients do we have that we put them on pred and mycophenolate and they don't get better? Is that because their disease is too advanced? Sure, plenty of times. Is it because we're not targeting the correct immunologic pathway? I think absolutely. And do we need to try a different drug? Of course. But for some of those patients, you give them a month of mycophenolate, 2 months of mycophenolate before you might say that they're not getting better. That might be 2 months of active disease that you lost time and the ability to manage them. So being able to know from the beginning, well, this is the suspected immunologic etiology that's going to best be responsive to Cytoxan, to cyclosporin, to veterinary rituximab, to some type of anti-complement therapy that hopefully will be developed. So it will, the lack of response is not, we see it all the time, and it's not always explained easily just due to the chronicity of the lesions that we see on biopsy. And a lot of that's probably because our therapy is not correct. And if you think about 90+% of all of our immune complex GNs likely being managed with mycophenolate, because that's what the WSAVA group recommended to get more experience and the side effect profile. And it's great, we had to start somewhere. But if you look at human medicine, that is never the case. It's never that you have, even amongst like membranous, it's not everyone gets this. There are multiple paths of therapy that are there that we should be reminded of when we are treating these patients. And when we don't have a clinical response, it might be that yes, they have a immune complex GN, but our therapy might be inhibiting the complete wrong aspect of the immune system, and maybe that's why they're not responding. So this paper put forth 5 categories of basically immune-mediated glomerulonephritis. We'll call it that. And I thought that it was an interesting way to categorize things, because it's not just relying on, the categories are based upon their pathogenesis, not their reactive pattern. So some reactive patterns might be present in multiple different categories, but the categorization is based upon the mechanism, which actually makes a lot more sense to then get you closer to understanding what the trigger is, as well as how might you need to treat it. So the 5 they came up with, the first one is secondary to infection. And this is where the glomeruli are involved either via humoral or cellular mediated mechanisms. I'm going to skip past the beautiful cartoon of the glomerulus, because I think we've all got that pretty well. But yeah, it's a great picture if you need one. So the infectious cause, those patients are often just treated with therapy to address the infection. And then when the infection is gone, then you will have you will not have any further stimulation of the immune system, and the GN will recover without any additional treatment. The second category is autoimmune glomerulonephritis, and those are that's an immune response against autoantigens. And so this is where we're going to have patients who develop antibodies against nephrin, against CURL1, against APOL1, against these antigens within the kidney themselves. It also could be antigens that are elsewhere in the body, and you could have a circulating antigen antibody complex that becomes deposited. So they're not all renal antigens, but it is a self-antigen that's causing it. The third one, which we don't see obviously very commonly at all in dogs, and I think maybe rarely, we'd really have to pull those cases. But the third one is all alloimmune GN, which is where we have a kidney transplant scenario, and there is a mismatch between donor immunity, recipient immunity against the donor tissue, and then much less commonly the opposite, graft versus host. We obviously do kidney transplants in cats. Many of those cats can have both acute and chronic rejection. I don't think we have a lot of work into the categorization of that. I think a lot of those cats don't get repeat or kidney biopsies, period, when they're having an acute rejection. I think it's more maybe when they pass away, we might get kidney tissue from them. Correct me if I'm wrong, Rachel, but I feel like we don't get a lot of, I mean, we get it occasionally, but we probably don't have a ton of graft biopsies in our patients that are having rejection.
Yeah, we get like one maybe a year, and usually it's not necessarily from concern for rejection, but just whether or not there was necrosis of the graft from original problems of the transplant. And I assume that Penn is collecting tissues at autopsy when people consent for autopsy at the end. They never submit them to us. So maybe there is a cohort of animals that are being kept at a vet school somewhere. That would be really interesting for us to look at to see if there is, transplant rejection. But they don't come to, it's probably because they assume that Texas A&M the IVRPS will be too expensive, but obviously we could work out a situation.
Yeah. Or maybe they still think it's going to be too slow. That's a common thing that we hear from clinicians all the time, that the patients are either dead or they're better by the time you get the biopsy, which is garbage.
But even just like autopsy from like whenever it's like they don't have nothing to treat, but now we're at autopsy. Sorry, I have house cleaners vacuuming and my dogs are going a little crazy.
So that's the third category, alloimmune GN, which I think happens likely in our patients, but we are going to have very little data for that. Fourth is autoinflammatory GN, and these are genetic errors of immunity. And this is really interesting in people because these are where you have, you can get excellent responses in these patients as long as you break what their autoimmunity is related to. So if you can figure out what the target is, and you can stop that process, these patients can do very, very well. And then the fifth category is the monoclonal gammopathy-like GNs, which are going to be depositions of monoclonal immunoglobulins within the kidney, and those patients are the ones that is going to be driven mostly by B cells and plasma cells. So something like Ritux is going to be the therapy of choice for a person, which we don't have readily available to us. So these are the 5 categories of immune-mediated glomerulonephritis that are proposed. And I thought this was a a reasonable way of categorizing things. I don't know what everybody else thought in terms of this, or if are you guys seeing this at all in the med schools in terms of ways that it biopsies are starting to get reported or looking at? Is this more just an article that's recommending something, or is this a frame shift that you guys are starting to see amongst your MD colleagues?
Yeah, so oftentimes when we are reviewing cases for rounds at OSU med school, they will, to their best of their ability, try to give you infection associated blah blah blah, so that the nephrologist will have the cause in the diagnostic line. And then kind of give the pattern. So for example, lupus nephritis, which is one of our autoimmune GNs, they have to have a diagnosis of lupus first before we can diagnose lupus nephritis. But then lupus itself can give multiple different patterns. It can give a membranous pattern. It can give a mesangial-proliferative pattern. It can give a membranoproliferative pattern. It can give a crescentic pattern. It can give a sclerotic pattern. So they would say lupus nephritis with, and then they would give the pattern. The pattern itself does have prognostic information, because if you have a lot of crescents, you're going to do worse. If you're all scarred, you're going to do worse. So having the pattern in that diagnostic line helps the nephrologist, but then having the etiology tells them kind of how they're going to do their treatment. So both of those, anything they can do where they have the diagnostic line as far as cause is going to be there. And then there's times where they don't have that information to correctly categorize it into this kind of group, like an infection-associated GN, and they're not really sure, but they think, oh, maybe this patient has an abscess somewhere. They'll just talk about the pattern, and in their discussion, they'll say, these are the things that we would think for this type of pattern, that it looks for an infection somewhere. Even if you didn't find something on your original scan, maybe it's, an endocarditis that you didn't look for because you didn't do a transesophageal EEG or whatever, not EEG, but the echo. So they'll say, look harder for a region of infection. But that would go more in their comments. But yeah, this is typical for what we diagnose.
Cool. So it's nice to see that it's actually getting some permanence rather than just a new academic categorization. So let's dive into some of these categories. So the infection-related GN, they list a lot of the different causes, and a lot of them are post-viral infection, which might be one reason that we might not see this very commonly in our patients. They see with post-streptococcal infections, which we occasionally will see strep UTIs, and then rarely it's a strep hepatitis, or it's just not an infection that's very common at all in our patients. But when we look at the list of things that are there, that we do have some things like parvovirus and coronavirus, which our patients certainly can be affected by, but we just are lucky that we don't have a lot of viral disease, or even that what we do, like tons of parvo, but we're not necessarily seeing that they're developing GN, but are we looking for it? Maybe it's probably not going to be at the time that they're sick and they're having diarrhea and they're leukopenic in the hospital when they were diagnosed, but it could be within the next few months. And are we keeping up with them? Are we checking urines? Are we keeping close tabs on those patients? To be honest, probably not. If their white cell count rebounds, you're probably not going to do much additional blood work once their total proteins are better too. So again, maybe this is occurring and we're just missing it. But there weren't a lot of triggers on this big list that I thought were very common diseases that we see. I thought what was interesting is that while some of those infections, and you think of all these different viruses, most of those are probably going to be the immune response to the virus wherever its source is, in the lungs, in the liver, in the upper respiratory tract, wherever, and then you're likely going to have circulating immune complexes that will become deposited. But you can also have in situ complexes, and they talk about how with group A, beta hemolytic strips, their antigens can attach to the glomerular endothelial cells. So you'll have the antigen that gets trapped there, and then you'll have the antibodies that will form around that trapped antigen. So it's not the circulating antigen antibody complex that gets stuck in the glomerulus, it's the antigen that gets stuck, and then in situ formation of complexes around it, which is just kind of an interesting thing that we can see with that. So they talk a little bit about how the strep toxins can bind, which very interesting, but again, I haven't seen a post-strep case of GN. Again, it's very uncommon that we see strep, period. And then the other pathway would be circulating immune complexes, and this would be with some systemic disorder. And we certainly worry about this maybe being the trigger, and if borreliosis is a trigger for immune complex GN, then presumably, since we have several papers that have shown that dogs with presumptive Lyme-associated nephropathy don't have an abundance of spirochetes within their kidneys, that is going to be either formation of circulating antigen antibody complexes that become deposited, or who say it's not something like strep, where you have an antigen that becomes trapped within the glomerulus, and then that leads to formation. Or this patient has had antibodies to Borrelia for years and years and years because they get exposed in their backyard every summer, and the pathology that we're seeing is 100% unrelated to the fact that they have a positive Lyme titer, which is the real truth, that even with a biopsy in a dog that's Lyme positive, we really cannot still say that those two are intimately related, that having a high C6 antibody level means anything for what's happening in the kidney. It could be completely different antibodies, completely different antigen that's targeting things. So it could be related, it could be unrelated, and that's probably one of our at least most well-known presumptive infection-related GN, and that's not even completely substantiated in my mind.
And I think it's interesting is, so I have an index of suspicion if I know they've had tick exposure. I don't necessarily need it to be Lyme, but if they've had tick exposure from any of the tick-borne diseases, and I see something that I'm like, that might be immune complex based on the histology, and I would go ahead and start treating and wait, while we're waiting for the EM and immunofluorescence. I think it would be reasonable to treat because we know we have a history of some type of tick-borne disease, tick exposure, I should even say. And then what I'm seeing in histology, that is, tick-borne disease is not something that ever jumps to the mind of an MD when they're thinking about GN. Like, they do not, like, when there's been cases where they're like looking at a biopsy, we'll be looking at it from a patient that moved from Colorado, had Rocky Mountain spotted fever in Colorado, and I'll be like, well, yeah, they could have, this could be from their tick exposure, and the MDs will just go, oh, yeah, I hadn't thought of that. Now it's really hard for them to prove too that that's what was the initiating factor, because it's just, as much as people get tick-borne disease, they don't actually get glomerulonephritis from it. Except for, have you guys all been seeing like Pfizer's developing a drug because they say Lyme can be in teenagers that are around dogs? There's like, I'm getting like a whole bunch of posts on Instagram about, there's a new study with Pfizer looking at Lyme disease in teenagers and young adults that are near dogs that also have Lyme disease. And I'm like, I don't know what their manifestation of Lyme would be, but I guess Pfizer's recruiting people for a clinical trial for it. I thought it was interesting. So maybe those are going to be glomerulonephritis. I don't know.
Interesting. Yeah, it's been a while since I've done the lit search, but as of the last couple of years ago, the last time I gave this type of lecture, if you had a Lyme-associated glomerulopathy in a person, it was still a case report. I think as of a couple of years ago, I think exactly 8 cases that had been published. And if you think about all the thousands and thousands of people that are diagnosed with Lyme disease every year, it's always made me nervous that we're just jumping to this diagnosis of Lyme-associated nephropathy in our patients without really being confident.
I agree. Rachel, was the drug for the dog or for the teenager?
It was enrolled to, it was recruitment for teenagers.
Okay, so it's a drug they give to. Okay.
Yeah,
All
to
right.
people, but it literally is kind of one of those things where I clicked on it once, so now I'm keep getting more ads. I'll send it to you guys, but
Okay.
it's, it literally says dogs can give your teenagers Lyme disease. Please enroll in the study.
Oh, great. And kill all your dogs. That's awesome. Oh,
So it goes through some of the pathogenesis of how pathogens, and a lot of these are viral infections, on how they can trigger immune activation within the glomeruli, and we'll kind of skim through that. And then they go through the targets for immunotherapy and benefits of corticosteroids or other immunosuppressive drugs to limit irreversible damage and infection-related GN remains uncertain, which is, I think, what we see certainly in our patients, that we get the diagnosis of immune complex GN. We're hopeful that we might have an opportunity to reverse some of their disease, but it's still a guarded prognosis whether that will be the case. And they talk about some therapies specifically where interferons are binding to and targeting the APOL1 antigen and being a major pathway of the glomerulonephritis, that these drugs, inaxaplin and baricitinib, are being still evaluated in clinical trials. So again, area where they might have a more targeted ability to break the immunopathogenesis on what leads to that pattern. So maybe there could be things like this. And for some of these drugs, they are going to be very, very specific to the human molecular targets, and depending upon the homology, they might not be effective in dogs or cats, but some of them might be. So we'll just have to kind of take it as they come, for sure. Okay, we have about 15 minutes left, so we'll keep going through things. So autoimmune GN, this is where we have an adaptive immune response against self-antigens that localize to the kidney or are expressed systemically. And the extra-renal antigens can become either, again, can have an antigen that gets trapped, or you have a circulating antigen-antibody complex that can become deposited within the GBM that can lead to then further in situ complex formation. And so they have talk about these very nephritogenic autoantibodies that are there, and then depending upon the titers, you can have both acute GN or chronic and slowly progressive GN. So depending upon the level of activation of the immune system, these patients can present with your acute PLNs that are rapidly progressively deteriorating kidney function. What I think of in my head is a rapidly progressive glomerulonephritis, which is what I see clinically, which is not the same thing in RPGN from a pathology perspective in people. That's a crescentic disease, which even those patients that clinically have rapidly progressive decline in GFR because of their immune complex GN, when we biopsy them, crescents are not a common feature that we see. But clinically, we have those that are rapidly progressive, circling the drain, that are going to die if you don't do anything, still could die if you do everything. And those that are more chronic, and like the case that was discussed on the ACVNU listserv, a patient with months and months of proteinuria, but progressive proteinuria, progressive decline in kidney function, hypoalbuminemia, that also could 100% be an immune-mediated process. So autoimmune disorders are not necessarily known for always giving one speed or another. I think that when they are acute, They're a little bit easier to have a good presumption, and many of those cases with an acute AKI, acute clinical decompensation, we think it's from glomerular disease. The vast majority of those have turned out to be immune complex GM in those patients that I've biopsied. Rarely we'll see something like an amyloid where it's probably more of an acute on chronic, and we dig through the history and there's more evidence of chronic disease that's there. But in the vast majority of those patients we biopsy, they come back immune complex, and we'll end up immunosuppressing them right away. The ones that are slower are harder. It's harder to know, is this patient going to have glomerulosclerosis, or does it have chronic immune complex GM? That's also probably causing some degree of sclerosis as well now, and that's really where you need the biopsy to be able to tell that as well too. They talk a little bit about IgA nephropathy here. We do see IgA nephropathy in our patients, not very commonly. We probably have, we talked about it a while ago, but we might have maybe 5 cases or so. I know I have one. But so we see it, but it's not a common thing. But this disease, it's IgA from the gut that is triggering systemic production of antibodies that are deposited within the GI tract.
And I do want to say that for IgA, it is the most prevalent cause of glomerulonephritis in humans, and that's because they have a different type of IgA than dogs have. They make 2 different antibodies, 2 different immunoglobulins, and some of them are poorly, sugars are added incorrectly. And so because the sugars are added incorrectly, it exposes a part of the immunoglobulin that then IgG binds to. I'm sure there are also IgA human patients which have just the stuff from the gut or whatever, but the more common, and the reason it is so common in humans, is because they're making defective IgA, and dogs just don't have that type of production of IgA. They make a different version. And even if they made the same version, it's not that they apparently make the sugars in a correct way. So I think that's what's annoying about this stuff, is that if we're talking about that, we're talking about measuring an immunoglobulin, but the immunoglobulin could be produced in the correct way. It's just whether or not the sugars were added in the correct way. So now we've got to measure galactosylated immunoglobulin. So it's so complex that it's really hard for us to say definitively what the cause of many of these diseases until we get a cohort of 1 million people, or 1 million dogs, that have a similar phenotype, and then say, well, what was wrong about their transcriptomics or their proteomics or their lipomics? What was the difference?
Yeah. We'll get there. We'll get there.
You have more positivity, but you're just a very positive person, JD, so.
Positively positive, this is breaking things up a little bit, but I wasn't sure what you guys thought. I didn't necessarily think that while the lesion pattern, which is what we often think of as historically our diagnoses, FSGS, neural change disease, MPGN, is angioproliferative, the structures that I injured made sense to me. But I didn't necessarily agree with their categorizations for the chronicity. I think that for MPGN, saying it's acute, we see plenty of MPGN patterns that have lots of sclerosis, that it appears to be a more chronic disease. And the history also fits with that as well too. So I didn't necessarily agree with feeling I could be confident in the chronicity of this table. So I would kind of just take that off personally. I don't know if anybody else.
Yeah, I think a lot more would fit into variable as opposed to what they have. A lot of them are variable. And I think a lot of this is also too when humans would probably be biopsied for these lesions, because humans usually tend to know that they're sick and detectable for proceed to biopsy in industrialized countries. So yeah, I think a lot of those end up being quote unquote variable, except for the stuff that's like the glomerulosclerosis, the tubular artery interstitial fibrosis. That's all chronic.
Yeah. Okay, they gave some beautiful images, which I unfortunately I think let's skip through unless any of you guys saw something particular that you wanted to point out. But clearly we're familiar with the patterns that we see. It was really not the point of this. They talk about ANCA nephritis and lupus nephritis here, which again are things that we don't necessarily have well understood in veterinary medicine, partly because of our ability to measure these various things that are present. Going into more the pathogenesis of ANCA nephritis, of C3 glomerulopathy. Oh, and how cool it is. So they actually have complement blocking antibodies. Eculizumab is one of the ones that are used in people, and so really finely tuned therapies, which are just totally different than throwing steroids and mycophenolate. What used to be called Goodpasture's disease, which is an immune-mediated attack against the collagen within the basal membrane of the glomeruli and the tip of the lungs, but could be other tissues as well too. Generally against the alpha-3 chain of type 4 collagen. So again, just giving different ways of targets essentially of the immune system that's attacking itself, the body. I like this table too. So they gave, here are 5 categories that are present, and they summed it up with very quickly their pathogenesis and what the therapy was. But then what I thought was really interesting and exciting about what we can continue to look at are the immunophenotyping that's there. And that's obviously from looking at kidney tissues, but even more so looking at some serologic markers, because that's probably the goal, the end goal. If we can find more either serologic or urinary markers that can tell us with a relatively high level of confidence what the pathology might be, then we're going to not only have more tools that we can use for our diagnostics, but maybe have better directed care for patients that a biopsy is just not something that their family, their owners are going to allow us to do. And we wish we could biopsy more patients. And these other markers are ways that we can get more information upon it, which I thought was interesting. In terms of the reaction patterns, this I thought is another big point too. When you look at these things that we see, mesangial-proliferative GM, well, you can see that with every category of disease that's there. Membranous, everything essentially except from the auto-inflammatory GM. Membranoproliferative, everything. So here's that disconnect, right? We get that histologic diagnosis, and we think that that's our disease. That's not true. It can be seen with any one of these pathways of immune system activation. We need to keep working. We need to keep looking at what these targets might be, what the triggers might be. The problem is, as we've said, lack of testing that's available, things that are expensive. We don't have insurance that's going to pay for hundreds and hundreds of dollars for infectious disease testing. To be honest, the way that I practice, I tend to get the patients, biopsy them, and then if they come back immune complex GN, I'm going to then come back around and do more infectious disease related testing and things like that, and which is a little bit different than what the WSABA consensus guideline says. They kind of say biopsy should be done after you've done all that stuff. Well, the problem for me is that even if I find a antibody to some infectious disease, I don't know if that's the trigger, and treating for that infection might not do anything. The classic case is Lyme. All these dogs that are Lyme positive, you just put them on doxycycline, they will not get better if they are proteinuria. They're not going to get better. They will die unless you immunosuppress them. So I tend not to spend hundreds, if not more than $1,000 on infectious disease testing unless I get a biopsy that comes back and says this is immune complex mediated. You should then maybe look at these triggers. Otherwise, I'd rather put that $1,000 towards the biopsy so I can say, oh, if it's amyloid, there's no reason I need to spend $800 on an infectious disease panel, because that's not the trigger for him. Let's save that money, and let's, not that we have a lot of other great options for amyloid, but at least we're not spending that money when we don't have to. So again, another big take-home point is the reaction patterns being essentially there for most, if not all, of those various types of categorizations of immune system activation. They give targets here, which these are basically the blood tests that Rachel was alluding to. So anti-PLAR, anti-nephrin, anti-NEL1. These are all blood tests that can be done in people. Maybe not every single one of these things, but the vast majority, they have a serologic test. There might be some that would be a urine test as well too. Certainly some of these are going to have more specific antibody staining within kidney tissue as well, but these are serologic panels that can be done that help allow clinicians to determine if it's active or inactive, and they can target therapy according to what the serology might be. And it's, for me, this is just exciting because this is where we could be. And I hope that we can get there. We certainly have a lot of brain power and a lot of smart people that could do it. We just need more grants and time to do it, for sure. Okay, we're coming to the very end. Let me just see if we have, there were many other major things. I asked myself a question. Have you seen this in dog? What's that? Antibodies against, these tiny dust-like IgG deposits, which occur due to antibodies binding to components of the slit diaphragm. And Rachel, I wasn't sure, have we seen these tiny, what's described as dust-like IgG deposits that are there? I think this is one of those lesions that is, you need to see it on frozen tissue rather than fresh fixed tissue, but is that something that you guys have encountered?
No, and so using confocal is a higher level of resolution, because you kind of go through a Z-axis as well, and we only use that beflorescence. And even at UNC and OSU, nobody does this routinely to use this. It would be more for research.
Gotcha. They talk about autoimmune disorders where something like plasma exchange to get rid of those antibodies could be there. And then the endopeptidase imlifidase can be used, which I had never heard of before. But that's an IgG-specific protease. And it's approved in Europe. I don't know if it's approved here in the US, but I think it's approved for treating kidney transplant rejection. But it cleaves IgG, and it's a way to essentially inactivate IgG. So I thought that was a very cool therapeutic approach. This figure I thought was great, figure 3, in terms of just putting cartoons to the different pathologies of how we can get to GN. It is cool. We don't really have time to go through all of the different aspects of it. Alloimmune GN, I don't think we can really cover that too much, both as well because we don't have the ability to diagnose as much. We don't do a lot of transplants, so it's not something we're going to see very often. And what else do we got? Oh, here, all these different drugs that are being investigated, and we can only hope that they might cross-track with dogs and cats and also not be ridiculously expensive. I doubt we'll find many drugs that will fit with both of those things. And then the last one is this autoinflammatory disorder, and that's from inborn errors of immunity. And these are the patients that can do very, very well, the humans that can do very, very well when that target is identified and they have a very specific treatment to break their cycle of attacking themselves, essentially. So a disease that's not very well understood in veterinary medicine, but is there. And then the last one is the monoclonal ones. So these are going to be patients who are going to have monoclonal deposition of immunoglobulins, and most of that is either going to, so it's going to be either B cell or plasma cells that are causing too much, and it could be related to neoplasia, or it's just a benign proliferation of these things, and we get this monoclonal gammopathy of renal significance. MGRS is what it's called, and that's where we have, it's not cancer, but these abnormal B cells are producing these antibodies that get deposited then in the kidney. And we've seen patients who have had a hyperglobulinemia that we dialyzed, that we could not get under control, and we've had bone marrows, we've had aspirates and biopsies of organs that have failed to show any cancer. So I think we have seen some of these in very, very rare cases, but I can't say we got any clinical remission in our patient. We essentially dialyzed it until we stopped, but it did not respond to immunosuppression overall. So again, things that are there, but maybe we're not using the right therapy. If you're looking at what would be done for plasma cells, it's going to be using rituximab, which doesn't work in veterinary medicine, but maybe our own anti-CD20s in the pathway, or other CD38 antibodies, which I don't think. So that's about all I had today. I mean, I had a lot more. It's a big paper, and hopefully everyone read it and was excited about future pathways that we might have in veterinary medicine to try to understand some things. Yeah, so I guess we're a couple minutes over, but we can open it up. If anybody have any questions or comments, as usual, I end up kind of stealing the show, but anybody have anything that they wanted to share, or questions you have, now's a good chance to bring them up.
I just want to make sure you were recording this whole thing, right, JD?
Yeah, okay. It's recorded. It'll get posted on the.
Okay, I just want to make sure because I was seeing the button wasn't even lit up, but I was making sure. And then also, the goal I can see from a person who looks at a lot of kidneys is to correctly diagnose them, enroll them into a study, because we have people who are now true veterinary nephrologists that can run a nephrology center, and then make sure that the drug you're putting them on makes sense for the disease. So trying mycophenolate on a whole bunch of dogs that you have not biopsied and don't know actually just have a podocyte problem and not an immunoglobulin mediated problem is going to show that mycophenolate is not a successful drug. So, and I'm very excited that the nephrology, nephrurology system exists now for training, but we also just need to make sure that we have centers of excellence that can then advise another small, maybe even a tertiary center to enroll patients so that we know that the right drug is being given to the right disease. And then also develop drugs that actually hit the canine version of what we think is going on, as opposed to just trying to use human drugs, is very helpful. But I think this is I mean, I obviously skimmed the paper because a lot of it was stuff that was fairly well known to me. But I think it is a very good way to kind of plan out how diagnoses work in human medicine and human nephropathology, and why you would actually take the time to figure out the correct diagnosis, because the treatment is completely different depending on the diseases. But there's lesions that I've seen in dogs that have never been seen in humans, so it's gonna be something we figure out, that eventually dogs just have their own kidney diseases.
Yep, and cats too. You know, we see
cats too.
Yes, but you know, cats are still an open book in terms of what they might have, and even though they tend to have maybe a better response to mycophenolate than all immune complex dogs do, we can probably count on 1/10 of all the dogs I treat for glomerular disease, I'm treating a cat for glomerular disease. It's just far, far less common. So still plenty of opportunities there for learning more and helping them out as well. So, yep, hopefully with the advent of the college, we'll have easier ability to do some multi-center studies and really support the development of people that have heard all of these things and are excited to learn more. I think going back to one of your earlier comments, Rachel, I remember being at during my residency at Wisconsin, and there was a kidney transplant cat that died. I wasn't involved in its care, so I don't know many of the details. But I remember it was being shown at necropsy rounds, and I was asking the pathologist if there would be, are we going to look, is there any chance, the cat had progressive kidney disease, and that's why it died. Does this cat have a calcineurin inhibitor nephropathy? Is that something that we're looking for? And the pathologist said, what's calcineurin inhibitor nephropathy? So, we're never going to diagnose things if we don't know that they even exist. And we don't know that they're going to exist unless we're starting to look and dive into the human literature and the human knowledge and understanding how dogs and cats act like and act dissimilarly to them. So it's really exciting that our college can start to generate that enthusiasm and help train people that are going to break the mold and start to look in other places that we can advance our understanding even more.
And I think, so what I get afraid of, JD, and this is going to be my soapbox, and then I'll stop because I have to eat lunch at some point, but we've obviously put a lot of data out there that you need a specialist and you need electron microscopy at the minimum to make sure you're accurate for certain diseases. Now, amyloid, you don't need it, but for certain diseases, you need EM to prove that there's deposits there. And I get worried that because the atlas exists and there are a lot of pathologists that work at Antec or IDEX or whatever that are plowing through cases, and there's people who can't, and I get it, people can't spend the money. But I feel that some pathologists are kind of flipping through our atlas and saying, oh, this one glomerulus matches this one picture in this one book. And therefore, and we've seen it, we've gotten second opinions from animals where the non-trained, non-nephropathologist has given the wrong diagnosis. They went down the wrong route. And then when the animal eventually was euthanized, the clinician has sent us the kidney and we're like, no, that was actually completely wrong. And from a research interest, we've been able to do electron microscopy to prove that we're right. But I worry that because we are disseminating this information and people still don't really understand why you would spend the extra money, and also not really communicating to the owner that, yeah, we're giving you a pattern, but that doesn't tell you etiology. It doesn't tell you the best treatment, that we might actually be doing a disservice. I know we're not, but it kind of upsets me that sometimes people are just using the atlas, flipping through it, and then saying, well, I have one single glomerulus in this entire specimen that matches that one, so it must be this disease.
Right. Yeah, and I think that comes to the clinical training too, that we need to have more of the clinicians that are actually obtaining the biopsies understand why they don't want to send it to their regular commercial diagnostic lab, because they're not going to get even an accurate pattern that's going to be shown, let alone the actual discussions on what the pathogenesis might be. But they're not even going to get a pattern that's accurate. So all things to continue to work on and improve in our field, but we're getting there. Pathways are being created, and we got nowhere but up to go. So,
and think of how, I mean, I don't want to be like my gray hair is showing, but think of how far we've come, right? I mean, when I was an intern, which again, granted, Reagan was in office, but when I was an intern, we were told, immunosuppression does nothing for proteinuric animals. They're all dead within 5 months. That was like Bob's your uncle. That was it. And I mean, we've gone from where we were to where we are. I remember trying to biopsy dog when I was in my first year of my residency, and everybody thought I was crazy because there's no reason to look at that. And we biopsied it, and I took it over to the nephrologist at the med school in Minnesota, and they read it out, and then everybody's like, well, no, you can't trust any of that because they don't know what they're doing. It's a dog kidney. I'm like, granted, but it's better than, here's a small bag of KD, good luck.
Right. Yeah, that's
So,
very true. We've come
yeah, so
far.
we've come so far. We've got a long way to go, but I think we've got the momentum now, and we're going to get there. I mean, like every time we have renal pathology rounds or every time we have any discussion, like I learn something new every time.
Yeah, likewise.
Sorry, I just.
No, it's a good point. It's a good point, Sherry. It's a process, and I think we have more momentum now than we've had previously, which is awesome. And let's build on it. I think we've got a lot of great people in our community that are fun to work with and super smart. So it's a good time. It's a good time to be in veterinary nephrology for sure.
Oh,
All right,
yeah.
I kept everybody far too long over the time period. I will go ahead and post this recording to the website, and then I need to look at the schedule to see if next month's will be during Renal Week or not. But if not, I'll come up with another article, send it out to everybody, and I'll send everybody an email when this is posted on the website as well too. So thanks everybody for joining in. Always so good to talk to you
Great
all.
job.
Everyone has a
Thanks,
wonderful
JB.
day.
Thanks, Rachel.
Yep, I'll see you guys soon.